Nephron protection in diabetic kidney disease. Kidney disease is a critical determinant of death from cardiovascular causes in patients with diabetes mellitus. Beyond medications that control glycemia and blood pressure, only medications that inhibit the renin-angiotensin system, RAS, have had robust renoprotective effects in randomized controlled trials.
The development of diabetic nephropathy involves hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria. Increased afferent arteriole dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure, which is associated with greater mesangial cell matrix production. Expansion of the mesangial area, an early morphological change with diabetic nephropathy, is caused by greater extracellular matrix deposition and mesangial cell hypertrophy. This expansion is associated with a decreased glomerular filtration rate and a reduction in the surface area for filtration, which marks the beginning of renal failure. As this process continues, the glomerular basement membrane thickens, and this may eventually lead to glomerulosclerosis. All of these changes in glomerular hemodynamics cause stress and strain on the kidneys, which, if left untreated, may result in renal failure.
The working units of the kidney are individual nephrons. Each nephron is formed by a glomerulus, which filters fluid from the blood, and a tubule, which modifies the filtrate through the resorption of water and some solutes, and the secretion of other solutes. The concentration of the final product, urine, depends on hydration, obligate solute excretion, osmotic load, and other factors.
Hello, in this video we will talk about diabetic nephropathy. Diabetic nephropathy is kidney disease or damage that occurs in people with diabetes. Causes and risk factors for this disease. Each kidney is made up of hundreds of thousands of small units called nephrons. These structures filter your blood and remove waste from your body. In people with diabetes, the nephrons thicken and slowly become scarred over time. The kidneys begin to leak protein called albumin, and it passes into the urine. The exact cause of diabetic nephropathy is unknown. Poor control of blood sugar is thought to lead to kidney damage. If you also have high blood pressure, the kidney is even more likely to suffer from injury. In some cases, your family history may also play a role. Not everyone with diabetes develops this kidney problem. People with diabetes who smoke and those with type 1 diabetes that started before they were age 20 have a higher risk of kidney problems. People of Afro-American descent, Hispanics, and Afro-American Indians origin also are more likely to have kidney damage. What are the symptoms of diabetic nephropathy? Often there are no symptoms as the kidney damage starts and slowly gets worse. Kidney damage can begin 5 to 10 years before symptoms start. People who have more severe kidney disease may have a poor appetite, feel tired most of the time, and have a general ill feeling. Headache, nausea, vomiting, swelling of the legs, and many other symptoms may also occur. What are the signs and tests? Tests your doctor orders can often find signs of kidney problems even on the early stages. So once a year, you should have a urine test. It looks for a protein called albumin. Because the test looks for small amounts of albumin, it's sometimes called the test for microalbuminuria. When you have diabetes, your doctor will test your urine for too much protein at least once a year. Too much protein is often a sign of kidney damage. High blood pressure often goes along with diabetic nephropathy. You may have high blood pressure that begins quickly or is hard to control. Your doctor will also check your kidneys with the following blood tests every year. BUN, serum creatinine, 24-hour urine protein, blood levels of phosphorus, calcium bicarbonate, PTH, and potassium. Also hemoglobin, hematocrit, and protein electrophoresis of the urine. A kidney biopsy confirms the diagnosis. However, your doctor can often diagnose the condition without a biopsy. A biopsy is done if there's any doubt about the diagnosis.
A recently published secondary analysis of the EMPA-REG outcome trial showed the renoprotective effects of empagliflozin, an inhibitor of sodium glucose cotransporter 2, in type 2 diabetes.
BUN, serum creatinine, 24-hour urine protein, blood levels of phosphorus, calcium bicarbonate, PTH, and potassium. Also hemoglobin, hematocrit, and protein electrophoresis of the urine. A kidney biopsy confirms the diagnosis. However, your doctor can often diagnose the condition without a biopsy. A biopsy is done if there's any doubt about the diagnosis. Treatment. The goal of treatment is to keep the kidney disease from getting worse. Keeping your blood pressure under control, usually under 130 over 80, is one of the best ways to slowly stop the damage to your kidneys. Your doctor may prescribe medicines to lower your blood pressure and protect your kidneys from more damage. Often the best types of medicine to use are ACE inhibitors and angiotensin receptor blockers, or ARBs. Eating a low-fat diet, taking drugs to control lipids, and getting regular exercise can also help prevent or slow the kidney injury. To help slow the damage, closely control your blood sugar levels by changing your diet, taking insulin or other medicines your doctor prescribes, by knowing the basic steps for managing your blood sugar levels at home, checking your blood sugar levels and keeping a record of it. Ask your doctor and a diabetes counselor how often you should be checking. Urinary tract and other infections are common and can be treated with antibiotics. Prognosis and expectations of this disease. Diabetic kidney disease is a major cause of sickness and death in people with diabetes. When it is caught in the early stages, kidney damage may be slowed with treatment. Once larger amounts of protein appear in the urine, kidney damage will slowly get worse. Often, it will lead to the need for dialysis or a kidney transplant. People with diabetic kidney disease often also have problems with high blood pressure, heart disease, and eye damage. You must call your healthcare provider if you have diabetes and you have not had a routine urinalysis to check for protein. Prevention. Before having an MRI, CAT scan, or other imaging tests where you may receive a contrast dye that contains iodine, tell your doctor. These dyes can further damage your kidneys. Commonly used pain medicines such as ibuprofen, naproxen, and prescription COX inhibitors, COX-2 inhibitors, such as celecoxib, which is Celebrex, may injure the weakened kidney. Always talk to your healthcare provider before using any of these drugs. Thank you for watching this video about diabetic nephropathy. I hope it was useful for you. Bye.
There were over 554,500 cases of diabetes in Ecuador in 2017.
Diabetic nephropathy refers to the kidney damage caused by both type 1 and type 2 diabetes. Because of the growing number of people affected by diabetes, diabetic nephropathy is currently the leading cause of end-stage renal disease in most developed countries around the world. Each kidney has millions of nephrons, each of which is served by a tiny capillary bed called a glomerulus. The tiny arteriole that approaches the glomerulus is called the afferent arteriole, A for approaching, and the arteriole that exits the glomerulus is called the efferent arteriole, E for exits. The glomeruli are a tiny cluster of capillaries that are physically supported by mesangial cells. So when blood is filtered, it moves through the endothelium lining the capillary, then through the basement membrane, and then through the epithelium lining the nephron, and finally into the nephron itself, at which point it's called filtrate. Now, the endothelium has pores that keep cells from entering the filtrate, and the basement membrane's negatively charged and repels other negatively charged molecules and proteins, like the protein albumin. Furthermore, the epithelium has a special cell type called a podocyte, which looks like an octopus because it has foot processes that wrap around the basement membrane, which leaves tiny gaps between its octopus-like projections called filtration slits. In diabetes mellitus, there's an excess of glucose in the blood because it can't get into cells. And when blood gets filtered through the kidneys, some of that excess glucose starts to spill into the urine, called glycosuria. In addition, when there's a lot of glucose in the blood, it also starts sticking to proteins in the blood, a process called non-enzymatic glycation, because no enzymes are involved. Because glucose can get through the endothelium, this process of glycation can also involve the basement membrane of small blood vessels, which makes it thicken. The process particularly affects the efferent arteriole, causing it to get stiff and more narrow, a process called hyaline arteriosclerosis. This creates an obstruction that makes it difficult for blood to leave the glomerulus, which increases pressure within that glomerulus. At the same time, the afferent arteriole dilates, which allows more blood flow into the glomerulus and increases pressure even more. High pressure in the glomerulus leads to an increase in the glomerular filtration rate, which is just the amount of blood filtered through per minute. And this is the first stage of diabetic nephropathy, called hyperfiltration. In response to this high pressure state, the supportive mesangial cells secrete more and more structural matrix, which expands the size of the glomerulus. This matrix deposition and mesangial expansion can happen uniformly, or it can result in little nodules within the mesangium, called Kimmel-Steele-Wilson nodules, which are tiny balls of protein. The thickening of the basement membrane counterintuitively makes it more permeable, allowing proteins like albumin through that otherwise would have been filtered out. It makes sense though if you think about our octopus friend again. As the glomerulus expands, the legs of the octopus naturally have larger gaps between them. In other words, the filtration slits widen, making it easier for substances to slip through.
The kidney in a patient with diabetic kidney disease differs from the kidney in a patient with non-diabetic kidney disease because hyperglycemia persistently inhibits the direct vasoactive effect of tubuloglomerular feedback. 50 years after tubuloglomerular feedback was defined, it now appears that SGLT2 inhibition may be able to correct the deactivation of tubuloglomerular feedback that occurs in diabetes, a feat that, in combination with RAS inhibition, has nephron protective effect.
So in the end, the key abnormalities in diabetic nephropathy are a thickened glomerular basement membrane, mesangial expansion, Kimmel-Steele-Wilson nodules, and disruption of the podocytes. Eventually, these changes damage the glomerulus so much that it's unable to filter blood normally, and the glomerular filtration rate decreases. Typically, diabetic nephropathy starts quietly, with no symptoms during the hyperfiltration phase. But over time, as more and more of the nephrons are affected, the kidney becomes less and less effective at filtering the blood into the urine, and the glomerular filtration rate decreases dramatically. Once the kidneys no longer can do their job of filtering the blood, a person enters into end-stage renal disease. Because there are no overt symptoms of diabetic nephropathy, regularly screening the urine of individuals with diabetes is super important. Microalbuminuria, which means excreting 30 to 300 milligrams of albumin in a day, is a reliable signal that diabetic nephropathy has started to set in. Excreting above 300 milligrams per day is considered macroalbuminuria and is a sure sign of a problem. Unfortunately, diabetic nephropathy is a progressive complication that can be significantly slowed down, but not completely stopped. Keeping tight control on hypertension and hyperglycemia is critical. Specifically, angiotensin-converting enzyme inhibitors, or ACE inhibitors, as well as angiotensin receptor blockers can be particularly useful. These not only lower blood pressure as a whole, but they also specifically reduce constriction of the efferent arteriole. By reducing this constriction, we reduce the pressure within the glomerulus, as well as the damage that comes from it. Alright, as a quick recap, diabetic nephropathy is kidney damage that's caused by diabetes, which results in glomerular basement membrane thickening, mesangial expansion, and sclerosis. An initial phase of increased glomerular filtration rate is followed by progressive albuminuria, then a gradual decline in glomerular filtration rate, and finally renal failure. This progression can be slowed by tight control of blood sugar and blood pressure, and the use of ACE inhibitors or angiotensin receptor blockers to decrease pressure specifically within the glomerulus.
Thanks for watching.